Hello, good morning, everybody. Thank you for attending this morning's coalition conversation presented by Mental Health Reform. Today, we're talking about the topic of suicide reporting. Um, Coalition Conversation Series is our opportunity at Mental Health Reform to talk about the big topics that are affecting the mental health space in Ireland today. It really speaks to our vision here of accessible, effective mental health resources and supports for everybody in the country. Suicide reporting is a critical aspect of how we can change suicide reduction policy and change minds. Timely, accurate data helps us understand the needs, the direct resources, and prevent further loss of life. Now, before I want to begin, I want to acknowledge that today's topic is an emotive one. It surely is. Suicide is something that can touch us all. It's touched me, and I'm sure it's touched people here as well through personal experience, loss, or the people we work with or care for. So as we move through the session, please take care of yourself and step away if you need to. If you can see the next slide, we do have supports available from the HSE, the Samaritans, which are represented here today, and then also a text hello anonymous line to 50808. So after the presentation, which will be given by my colleague Roisin, we'll move into a panel discussion with three exceptional experts. Today we have Fiona Toomey, who's the founder and CEO of HUG, Professor Paul Corcoran of the National Suicide Research Foundation, and Sarah Stack, who's the head of communications at Samaritans. Together, they'll all share their insights, expertise, and reflections on what we can do to strengthen suicide reporting, suicide reduction, and postvention supports across Ireland. Throughout the webinar, as with any webinar, these are only good as the feedback that we get and the questions that you can pose. So if you're looking at the bottom of your screen, you should see a Q&A function. That's the questions and answers function. So throughout the presentation, if there's anything that comes up for you or any queries you may have, please jot them down, and then they can be used to shape the discussion at the end of the meeting. That's where we finish with an open conversation with our panelists, exploring the key themes that arise from both your own questions and questions provided by our moderator. That's Louise, our research policy and research manager, who will be doing a deep dive into the topic with the panelists and Roisin. So with that, I'm pleased to introduce our first speaker, Roisin Farrelly, my colleague, Research and Programs Officer, who will be sharing insights from the latest data prepared by Mental Health Reform. Okay, thanks. Over to you. I'll be handling the slides, Roisin, so just give me the nod. Okay, thank you.
Thanks a lot, Steve. Yeah, as you've already touched on, I guess suicide is quite an emotive issue that can have an impact on people listening to it. And talking about topics like this, I want to note, we're kind of talking large numbers and the value of reporting, and I don't want that to come across as if we're not taking the individual issues seriously, or that an individual's death by suicide isn't a unique, complicated and tragic thing. So just to note that we're just talking large numbers, but bear in mind always that it's each figure involves a real person and has a real impact on a wide number of people. Go ahead there, Steve. Thanks. So just to start off, Connecting for Life is Ireland's national suicide prevention policy. And the seventh final goal in this policy is to improve data and research when it comes to suicide. So in addition to a lot of really important work being done in terms of preventing suicide, it's vital to understand the issue better. It's the only way that we can ensure that the interventions that we introduce for suicide prevention are operating effectively, and that the populations that are most in need when it comes to suicide are getting the attention they deserve. So that's essentially why we're presenting this information, why we're having this discussion, is we want to ensure that we are looking at the correct suicide numbers, that the accuracy is as good as possible, and that we get them as rapidly as we can in order to then provide the best services possible. Thanks. So just looking broadly at the issue of suicide as we currently understand it in Ireland, These are figures from 2011 to 2021 as reported by the Central Statistics Office, and they only go up to 2021 because that is when we have the last official suicide numbers. We have more recent years, but they do not include deaths that are registered late. So if we're looking at kind of 4 years or 3 years out from data, there are things that we can miss in terms of more rapid changes in the numbers of suicide deaths. The other, key thing that we notice about suicide deaths, both in Ireland and internationally, is that the majority of them are males. So in Ireland, we're looking at almost 80% of suicide deaths tend to be by men. And another group that I really wanted to point out here are the traveller community, who we believe around 6 times more likely to die by suicide than the national average. However, we don't, again, get those numbers reported year on year in terms of how many travellers are dying by suicide. And that's because of the nature of, we're not collecting that demographic data. So again, that speaks to kind of our understanding of populations most at need, and there are indeed other priority populations noted by Connecting for Life that we would love to get more kind of information on, up to date about their risk of suicide over time. So just looking at the figures that we do have here, we're looking at above or around 500 deaths by suicide per year. That hasn't fluctuated a huge amount since 2011. So, I suppose that's interesting in terms of, it would be reflective of international trends also, that there might be a small decrease in suicides over time, but in a lot of high income countries, there's the figures are saying around where they're at. And in terms of Ireland's place compared to international countries, Ireland has the 17th highest suicide rate in Europe. So wouldn't be the highest, but also not totally on the low end either. Go ahead, Steve, thanks. So how is suicide determined in Ireland? When there is a sudden or unexpected death, that death is then passed on to the coronial service in Ireland. So coroners will investigate to determine the cause of death. And in the case of suicide, the standard of proof they need to meet, the level of evidence they need, is called beyond a reasonable doubt. So they need to have enough information available to indicate that there is no reasonable doubt that what occurred was a suicide. There's no other logical explanation of why that death occurred. So this would be quite a strict standard in terms of the evidence needed, and it would be the standard needed to prove a crime was committed. It's a criminal standard. The reason that is the case in Ireland is because under common law, suicide was a crime, and it was decriminalised in 1993 in Ireland. Of course, the consequences in terms of punitive, punishment for having committed that crime were not in place up until that point, but that was when it was decriminalised. And the alternative I have up here is on the balance of probabilities. So if we were to move away from a beyond a reasonable doubt standard, it would be towards this, which allows for coroners to take in kind of more subjective information about a person's situation before they died and as they died, to determine if it was likely that it was a suicide. So it's not a totally loose standard, but there is more of an opportunity to collect evidence and consider it as a whole to then suggest that it was likely that a person died by suicide, and this would be referred to as a civil standard. Thanks. So if suicides, or what we think are suicides, aren't being classified as suicides according to the standard of proof that we have, what are they being called? They would tend to be marked, if there's not enough evidence, by coroners as an open verdict. So we're not sure. Events of undetermined intent, so situations in which a death could have been intentional or could have been accidental. If there's not clear evidence, for instance, a suicide note as to whether a person intended to die, for instance, in a car accident, it might be determined as undetermined intent, or indeed as an accidental death or kind of misadventure, this might be referred to as. And this might happen more with certain groups. So I fear passive deaths would be more likely to be misclassified, as we're not sure whether the intent was to die by suicide. And just to note as well, as I mentioned, the majority of deaths by suicide are male deaths. And there is research also that women, when they do attempt suicide or die by suicide, they tend to choose more passive methods. So these are things like dying by poisoning or exsanguination, so blood loss, that these are deaths that, for maybe social reasons, women are more likely to opt for that method because they're less messy or less violent. And they're also the deaths that are less likely to be classified as suicide. So if there were a change in how the classification were to occur, and we had less deaths that were misclassified, we might see a small increase in the number of female suicide deaths reported. And then similarly, deaths of older adults that could have been a suicide might be more likely to be reported as undetermined intent or open verdict. And that's again there might be a social tendency to believe that older adults are less likely to be dying by suicide than they actually are. Go ahead, thank you. So what is the issue then with if suicides aren't being correctly reported as suicides? Why does that matter if they're still being reported as deaths? There's on an emotional level, it can have an effect on a bereaved family, bereaved friends, or community if you believe that a person died by suicide, but they can't be classified that way because of the evidence available. And there's also differences in the support needs that people would have in a community if a person died by suicide versus accidental. So it would be really important to get that right on a individual level when we're looking at deaths and supporting people who are bereaved by suicide. As well as that, as I mentioned, it's really important in order to address suicide that we have a good understanding of how many suicides are taking place and ultimately what is the burden of suicide, how big of an issue is suicide in the country, and if that's a bit less than we think it is, there might be less money allotted to it in terms of providing services and interventions. As well as that, if our death rates by suicide aren't accurate, it affects how we can compare them to other countries internationally. So again, as I mentioned, you might see Ireland's doing quite well in terms of suicide, but those comparisons become less meaningful if we understand that there's quite a significant amount of inaccuracy in those numbers, both in this country and elsewhere. And then as well as that, directing services where they need to be in terms of areas, in terms of specific populations. So perhaps women and older people might not be getting the attention they deserve if their deaths are more likely to be misclassified as not suicides. So the question might be then, where has already changed this burden of proof? Of course, suicide was criminalised under common law in Ireland, so it would have also been the case in the United Kingdom. And it's a really helpful example to look at as a country that has changed their burden of proof. So they had been working on the standard of beyond a reasonable doubt, as we are, and then they moved towards on the balance of probabilities. So this was the case. This change happened in 2018 in England and Wales first, and it was based on a Supreme Court case. So the situation was an individual had died by hanging in his prison cell, and the senior coroner at the time determined that this had been a suicide, not using beyond a reasonable doubt, but instead using a narrative verdict, so on the balance of probabilities. And this was taken to the Supreme Court because his brother, the deceased person's brother, appealed this, and it was determined that this was a reasonable and legitimate way of determining a suicide. So essentially, this set a precedent that they could lower the standard of proof in England and Wales from the criminal standard to the civil standard. And we can have a look then at what the initial effects of that change were in those countries, if you don't mind. Thank you. So the Office for National Statistics, so the UK official body for statistics, in 2020 made a report on the initial outcomes of that shift in the burden of proof. So you might expect that there'd be a direct and quick rise in the number of suicides, but they reported that it was in fact more gradual, and it tended to be that deaths were redistributed to different categories. So in this case, of course, they were more likely to be placed in the suicide category and less likely to be considered to be undetermined intent. And there were also fewer deaths that were attributed to accidental drowning and accidental hanging. So what we're looking at there is those numbers before the change happened and the numbers directly after. So they kind of did go up where they would have been expected to go down, but it wasn't a sharp sudden rise. And it would be important then when looking at those figures that all those graphs are kind of marked with that date of when that was changed, so that kind of people processing and reading wouldn't think, oh, there was just a rise in suicides. This was a change in classification, and likely the suicides had been occurring before the change had happened, but being misclassified. And then we have some evidence, or some research rather, of how that might look if the same change happened in Ireland. And the way we can do that is by comparing our existing kind of patterns of suicide over the last years in Ireland and the same in the UK. And this was actually a report commissioned by HUG and conducted by Indicon using difference in difference analysis. So looking at the numbers in the UK versus in Ireland, based on when the UK changed their standard of proof. And the ultimate finding from this report was that if that change were to occur in Ireland based on how the deaths that might be suicide look like, there would be a 20 to 25% increase in reported suicide deaths. So if we're talking about like in 2021, there were 512 deaths by suicide, that might go up by about 100 people if the standard of proof were to be changed. And then they also examined it using more modest estimates, so using different death categories based on the ICD-10, and that would be looking at a 10 to 20% increase. And then another source that would be really helpful to look at here is the Irish Probable Suicide Death Survey, which again would examine both suicides as determined by coroners, but also deaths that aren't determined as suicides by coroners but could be suicides. And they will look at the evidence collected at the time of the death and say it was likely that this was a suicide. And according to that survey, you'd be looking at 31% of suicide deaths aren't being classified that way in Ireland, and instead are being attributed, as we mentioned, to that category of undetermined intent, open verdict, or accident, or misadventure, or indeed no verdict at all. So that was kind of what it would look like if we changed the standard of proof. I want to fly back to what I mentioned before about how we only have the most recent official suicide figures from 2021. And you're looking at it here and seeing, well, you've got the last 4 years also. So these are the CSO Vital annual report statistics. It takes a significant amount of time for a coronial inquest to occur in this country. And there are other factors as well that mean that deaths that are officially determined as suicides aren't available as official numbers right away. So there's a bit of a delay, and that delay allows for late reports. So deaths that have occurred in that year and then haven't been officially added to the numbers or determined as suicides until some time after. So the most recent, in 2021, there was an annual report 2 years after that said 449 deaths by suicide had occurred, and then allowing for those late reports, the official number now, according to the CSO, is 512. So it's about a 14% rise from what the annual report said, which was published in 2023 in relation to 2021, and what actually came up. So those last 3 years there, 2022, 2023, and 2024, aren't the official numbers, and indeed we can assume that they're not as high as the numbers actually were. We're waiting for the annual, the late registered deaths, which will likely bring those numbers up by 15 to 20%. So is there any kind of solution to this delay, and why is it so unhelpful to have such a delay in reporting in terms of how we understand the issue of suicide and recent events such as COVID that might have given rise to changes in suicide numbers? Go ahead there, Steve. Thank you. Yeah, so the solution that we're putting forward, I guess, is the option of real-time or near to real-time reporting systems. So these do not replace official suicide statistics as produced by the Central Statistics Office or the Office for National Statistics or anything like that, but they make use of reports that are available closer to the time of death to gather evidence figures in relation to probable suicides and then present them to the bodies that need them. So this would be anyone from government departments of health to organizations that are providing direct support for suicide prevention, bereavement supports. And this is just kind of a general sample of how these systems work in the countries in which they've been implemented. So there are systems for real-time or near to real-time reporting in the UK at the moment, in various places in Australia and New Zealand, and indeed here in Ireland. And I'll get more specific about the real-time reporting systems available in Ireland. But how they all generally tend to work is that a death that is flagged as a suspected or likely suicide will be reported based on either a police report when they'll visit at the time of death, or the initial report made to the coroner. These tend to be recorded electronically. They might be sent by encrypted email, by data sharing, or by phone call, possibly, or direct visit. And there's a huge amount of variation in the amount of data that can be gathered. You know, as a research head would say, oh yes, collect as much data as possible. We'd love to know kind of the demographic groups that person belonged to, how the death might have occurred, their mental health history, their history of substance use, their health history, whether they were known to the health system, all that kind of thing. Think of how useful that could be to know right away or close to right away. But it's about kind of the capacity of these systems, and they all tend to gather the demographic info, so person's gender, sex, age, the mode of death, and the location of death, and then they vary in the amount of additional information that they might gather and the completeness of that data. And how kind of up to date or recent are these real-time reporting systems compared to the 3 or 4 year delay that we're looking at with the official statistics? They might be available directly as the deaths occur, or more likely kind of monthly or annually. Reports will be provided to the bodies that are interested or that need to know on a specific basis. And thinking about why kind of bodies might need to know is especially identifying multiple suicides that are happening in one area, or particular locations that seem to be having more suicides than they have had in the past, so that those organizations can then direct intervention where they need to go. And the other important thing to point out about real-time reporting systems is kind of across the board, they tend to be accurate and complete. So the guards or the coroners or whomever is gathering that information, and the people who are working with the statistics tend to get it right. They tend to get the important demographic info gathered at the time. And as it turns out, then when they're later compared to official numbers, they tend to be kind of correct in determining whether deaths were suicides and then counting them as suicides for these systems. Go ahead there, Steve. Thank you. And as I've kind of alluded to, how these systems are used in various ways are identifying trends or changes in suicide deaths as they happen, rather than a couple of years down the line, which is really important then in terms of understanding what is working, what isn't working, what are the threats to people's lives, and moving on from that, then what policy changes are needed, what service changes are needed to address these issues before they continue, rather than after they've already kind of run their course. There are examples, and I'll mention one specifically, of how these notification and real-time systems can be used to provide very localized bereavement supports. So suicide is something that comes with significant risk to the people around a suicide death, in terms of they might be more likely to die by suicide themselves, but they might be more likely as well to experience mental health difficulties, of course, and a significant amount of grief as a result of that. And there's a special risk then for children and young people when it comes to that. So directing kind of community-based supports where they need to be when a death by suicide has occurred would be a really big thing that real-time suicide reporting systems could help with. And then cluster prevention. So the suicide clusters, there's a lot of kind of talk about them in the media, but actually, I'm happy to move on to the next slide there, Stephen. We'll get more specific. Thank you. So when more suicides occur within a specific geographical area across a social group, or more so than would be expected, or in a kind of close time frame, that would be a suicide cluster. And that could be anything from 3 deaths and above. And if we're identifying these as they happen, it's possible that further suicides in that cluster can be prevented, and as well as that more support can be directed towards those areas where they're needed. And a related concept is suicide contagion. So the increased risk of suicide that occurs when an individual around you exhibits suicidal behavior or dies by suicide. And this can be of particular concern with adolescents and young people. Another thing I'd note as a risk that's kind of well discussed is the presentation of suicides in the media, either by a famous person or kind of fictionalized in television shows and things like that, can be seen to present a particular risk to young people. And real-time reporting systems are useful as well. And that way they've been applied to identify misinformation online when it comes to suicide, that there might be kind of headlines or social media posts about a number of people having died by suicide in an area, which would present risks for suicide contagion. But a real-time reporting system might be able to identify if that's true or not. And then if it is untrue, to debunk that and therefore reduce the risk of suicide contagion. Thanks, Steve. So a pretty recent report that is really interesting. I'd recommend if anyone is interested, HSE commissioned report or evaluation rather of the suicide observatories in Cork and Kerry that were operating from 2019 to 2022, conducted by the University of Melbourne. So the suicide observatories were, I suppose, demonstrating the possibility of real-time suicide reporting in Ireland in those particular regions in Cork and Kerry, and doing so by interacting with the coroners in those regions. And then kind of this was an evaluation of how that system operated and whether it would be possible to scale that up to the entire country to have that similar model of interacting with coroners and identifying possible suicide deaths, collecting that information, and then directing it where it needs to go. So the results of the evaluation I have here, which was they looked at the sensitivity and the positive predictive qualities. So that is the ability of these systems to accurately and correctly identify deaths that might have been occurring due to suicide. High data completion levels, so particularly with the demographic information, as I mentioned previously, these reports were filling all those fields out to a high level of completion. The completion rate dropped a little when we're looking at history of substance abuse and domestic violence, which would be considered risk factors for suicide. And it was just that it was harder to identify that at the time when the initial report of the death took place, which is understandable, and might be something that could then be later identified and followed up on. And the other thing that this report did was interview stakeholders, so people involved in collecting, analysing, processing the data, sharing the data, and the stakeholders found that the system as it worked was acceptable, so they could work with it, and useful so that they could see how helpful it would be for their work or for suicide prevention generally. And then when looking at improving or scaling up these systems, whether this is a possibility in Ireland, I certainly think so. And the recommendations made to do so were to standardise procedures. So people in Cork and Kerry might have a good relationship with the coroner as they're gathering the data, and that might work really well. But can we be guaranteed that that would occur in every part of Ireland? Not necessarily, and the way to ensure that would be to set procedures that operate the same way in every place in which this data were being collected, to make sure that the data was all collected to the same level of completion, and that to the same kind of quality as well. Another recommendation was to formalise data sharing agreements, so both with coroners, but in addition to that with the police service, so the Gardaí. As I mentioned, a lot of real-time or near to real-time reporting services in other countries will have a relationship with the police, and it'll be the police that notify of the suspected suicides. This is a recommendation of the evaluation, that there be data sharing agreements here. In addition to kind of having a standardized procedure as these models expand, that they be adapted to the local needs of the region. So, for instance, Dublin, if there were to be a similar model in Dublin, there's kind of a much larger population. There might be different needs in terms of service provision and stuff like that. So it'd be important to consider both the standardization and the flexibility of the needs of each region as you're adapting to that. And another brilliant recommendation of the report was to expand to include self-harm data. So we have a self-harm registry in this country, and it's, there's certain value in considering self-harm as a risk factor for suicide, self-harm as it interacts with suicide and suicide contagion and things like that. So, a possibility, if we were to introduce a real-time reporting system in this country, would be to combine those sources of knowledge and to be able to have those figures in relation to both self-harm and suicide together. Thanks, Steve. So as mentioned, just another kind of case study of the operation of real-time suicide systems. This is a data sharing service that existed in New Zealand, which again interacted with coroners, and the suspected suicides, as they were reported, would then be directed to the specific district health boards where the suicide had occurred based on encrypted notifications. And then those health boards would allot community-based postvention, so postvention being supports available to the direct community of the deceased person quite rapidly after the death had occurred. So there's a real value to that in terms of timely support as and where it's needed. And this suspected suicide data sharing service was also used to identify suicide clusters. So how systems tend to do this is selecting a search area size of how many kind of suicide deaths would be expected in a particular area, and then if the number in that area exceeds what would be predicted, that might be a flag that a suicide cluster is occurring, and then that can be identified and further examined. You can go ahead there, Steve. Thanks. So I hope this is a point that I've been making throughout, but what would be kind of why it's so important that we have information up to date and accurate in relation to suspected suicide deaths, as opposed to further down the line, that it could drive effective prevention and resource allocation. It's really important for kind of prevention services that are introduced, that they can be directed at the time that they're needed, but as well as that they can be monitored in terms of their effectiveness. So we know we're allotting the resources that we have for suicide to the correct services and programs, and then this can be built into policy, as mentioned with the Connecting for Life strategy, that there's goals in terms of suicide reduction for the general population, for specific populations and various service provisions, and having the real-time data would be a way that we could monitor those strategies as they're implemented, as opposed to at larger intervals. Helping at-risk groups, so identifying particular age groups, racial minorities, and gender that might be at particular risk of suicide, identifying when those trends occur, or when there's increases in certain suicide rates, not just generally, but in those specific groups. And as I mentioned already, emerging clusters can be identified and addressed. So supporting bereaved families, I've mentioned that also. The idea of interim certificates. So some may be aware that when a coronial inquest occurs, the death certificate is only available when that has been completed, and death certificates might be necessary more rapidly for certain kind of practical things around, monetary insurance and that kind of thing, and identifying probable suicides and identifying their cause as likely suicide might allow for the availability of an interim death certificate and the target supports, as I mentioned before, and as well as that the real-time information, because it works with probable suicides as opposed to officially determined suicides, might be helpful in terms of demonstrating the need for changing legal standards from that higher criminal standard to the lower civil standard, on the balance of probabilities. So it's helpful in that kind of illustrative way as well. Thanks, Steve. And the evaluation that I mentioned by the University of Melbourne has mentioned some of these, and these are also things that I've come across in other research. What would be difficult if we were to try and implement a real-time or near to real-time suicide reporting system in Ireland or anywhere. Data security would be a concern in terms of having that quite sensitive information sent, and that it would be kind of seen only by people who need to be seeing it, and it would not be kind of insecure to hacking or anything like that. So that would be something that would be really important in the initial development, that there's adequate IT infrastructure, that there's clear GDPR regulations in place, and that the software is future-proofed in terms of being adaptable as data security needs might change. The health system in the country is regionalizing, so this will kind of give rise to more different operations of the health system in the various regions in Ireland, as opposed to the operation being centralized as is currently the case. And when that happens, will there be kind of inconsistencies in terms of how data is managed or how interventions are delivered? I don't think it would be an issue. I actually think there's kind of a value in adapting to those regional and local needs in terms of suicide, but it would be something that would be important to build in terms of developing a real-time reporting system, is how those regions would interact with each other, how they might share data, and how they might interpret one another's data and things like that. This is something alluded to, that there can be unsubstantiated reports of suicide or substantiated kind of but unhealthy discussions of suicide on social media, which would particularly affect young people, but do kind of affect everyone. And it's difficult to address the kind of the accuracy of those things, or to kind of deal with people's fear as they read those online reports. And real-time reporting systems are a tool that can be used to address this, and it's important to kind of look at how that would be managed by real-time reporting systems when they identified suicide contagion or risks of suicide contagion in social media. And the existing infrastructure and models, you need to work with the systems that are in place, and as well as that, ensure that staff that are tasked then with operating or participating in a real-time suicide reporting system aren't overburdened, because that can then threaten the longevity of the system or the kind of data quality. So it's a balancing act, I suppose, of what is in place currently and what needs to be put in place to work with the system that we have, but which will fulfill the needs and do a kind of justice to a real-time suicide reporting system in this country. So not to end on hopelessness, I really do think there's strong precedent, strong will for both of these changes, the change to the burden of proof and to the possibility of a real-time reporting system. And the work that's been done in Cork and Kerry has been fantastic in terms of demonstrating that. And I think that leads on well enough to the discussion period.
Great. Thank you so much, Roisin. Really appreciate that presentation. I'm just going to stop sharing now. For those of you who are interested with the content, the presentation, the briefing note that Roisin prepared, further reading as well, like the recent observatory results are available on our Coalition Conversation website. So they're free to download once the webinar is concluded, and a recording of this will also be uploaded later on in the afternoon. So with that, moving along, thank you so much, Roisin. I'm going to pass the baton now to Louise, who's kindly offered her time to moderate a discussion and get to know the expert opinion from our panelists. So with that, over to you. Thank you, Louise.
Thanks very much. Thanks to everybody who's come today, and to Roisin, who has so eloquently summed up the report that she's worked so hard on. And just to note as well that there were a lot of organisations who fed into this report. We had a stakeholder group, we also spoke to coroners and lots of different people in the sector, and it's been really great, that the responsiveness that we've had. But I suppose to speak to the real experts in the area who've kindly given us their time. So I thought we might just have a few questions. I might just do one question per person and see where we go. Sorry, my computer's beeping there. So I might start with Fiona from Hug, who's the CEO at Hug. And what the question I have for you is, so Hug are advocating for a lowering of the burden of proof in the coroner's court. What impact would this have on the provision of post-vention services that Hug deliver, and that so many different community and voluntary sector organisations deliver?
Thanks, Louise, and thank you for that question. I think, as Roisin illustrated in her presentation, the importance of having real-time data and having a burden of proof that goes along with that actually is in line with both the law and with our partners across Europe is absolutely imperative. All this talk of statistics and numbers and accuracy are, as was mentioned, human beings, people who have lost their lives to suicide and who have left behind thousands of people who are bereaved and who need accurate and timely supports. Unless somebody has gone through the coronial system, they'll be unaware of the burden of proof. They may not even be aware of what this really means. But in essence, again, Roisin touched on it. If we have a standard that is beyond a reasonable doubt, it automatically will exclude a large number of probable deaths by suicide. You know, we ourselves did a statistical analysis through Indicon, which was mentioned, which brings the numbers up by approximately 25%. And then the National Office of Suicide Prevention also conducted their own study, the ICDS study, which brought the figure up by approximately 30% by going over coronial records. So to bring this back into the human element, what it means is that people impacted by suicide need timely and accurate supports. If we don't know the size of the problem, how can we provide a solution? How can we bring in timely and accurate supports if we don't know where or when somebody has died by suicide? Factually, we know that people who have been impacted by suicide are initially at a 10 times higher risk of dying by suicide themselves. They are 80% more likely to drop out of college or employment. They are more likely to, if they don't have the correct supports, to use maladaptive coping, alcohol, drugs, and risky behavior. All of these things can largely be mitigated if we know where and when these people are and get them the timely and accurate supports. So it really is a life-saving measure. You know, we can talk statistics and that's important, but it is absolutely life-saving to get people the right supports at the right time. And that circles right back to the burden of proof and accurate and timely data been shared.
Thanks, Fiona. It's so true, and that's, there's so much more that goes on, outside of the data, and the ripple effect of suicide, providing supports after identifying, the potential for suicide numbers and clusters to go up. So you really, eloquently there, brilliantly, summed it all up there for us about the importance of this real-time data, and the real human cost and need for it. I might just jump over to Dr. Paul Corcoran, who is the head of research at the National Suicide Research Foundation. Thanks so much for joining us. So my question to you, Paul, is how does the suicide recording process, and especially the reporting delays, affect the way we interact with official suicide data in Ireland?
Thanks a million, Louise. Yeah. Well, as a researcher, we always want to be examining and understanding the most recent data that are available. And unfortunately, that's one of the main features of the reporting process regarding suicide in Ireland, is that process is very slow, and the most recent data that are available are not accurate. So that when we see the figures, and Roisin showed some of the figures in the most recent years, we're talking about, mentioning of 300 or so deaths, which then when we read later, and these may get coverage in the media in general because they're recent, they refer to the year before, and so people are, able to reflect on that. And unfortunately, then when people see a later report a year later that may have added 50 or 80 or 100 deaths to it, many people have already moved their interest. Whereas for researchers and those who are in stakeholders in the area of suicide prevention, they become frustrated that now we're getting a different figure for the same year. And then a further year goes by and another figure will be provided. So we can end up with, 100 or 150 more deaths associated with a year if we wait 3 years to find that out. So it really reduces our value that we hold in the data. It feels that we've uncertainty, and we're not sure what exactly the main figures are, and that's coming before understanding the causes of which groups are at higher risk, which areas might be have higher rates. So we're quite frustrated, I think, in the way that impedes prevention, it impedes intervention for people who have been bereaved. And for researchers, it impedes just even knowing what is the actual figure, and can we believe that this is true, or is the process changing as it does over time, and it may catch up and then lead to more deaths being kind of registered quickly. So we're really in an uncertain situation, which isn't satisfactory, really.
Thanks a mil, Paul. It's great to have you kind of talk about the intricacy of the data, because it's we read a report and we take it at face value, and then to go back, I know as a researcher myself, to look at that report or those numbers further down the line and be like, what, to try and understand then why they've changed. It just highlights the importance of having real-time data so that we can really understand how the context in Ireland. I'm just going to jump over then to Sarah Stack, who's head of communications in Samaritans and has worked a long time in the suicide space. So what can we learn from other countries such as the UK about the initial impacts of changing suicide reporting methods?
Yeah, as part of the work for this, I spoke to officials at the Department of Health in England and Public Health Wales just to see how it works there. And it's really interesting. It's called kind of near to real time suspected suicide surveillance. So, for example, in Wales, 5 days into a month, they will get the entire month's suspected suicide data. So on the 5th of November, they will have all of October's data from the police into the health authorities, and then they will issue that data. High level data gets issued annually, but more detailed data gets issued every month back out to suicide prevention officials or professionals across the health boards and in charities like Samaritans and other areas. So they can identify if there is things like clusters, is there locations, is there methods, is there an age group. So it's quite high level data. It's not getting into specific suicides, but it is a way for groups and other bodies to try and respond quicker to suspected suicides. They did an impact survey of their last report, and they said that part of the feedback they got was in some areas they've been able to work really closely with agencies to respond to suicide incidents. They've been able to see which groups are at risks in certain areas and try and respond there with prevention methods. So as well as the supports like Fiona spoke about, it's the prevention methods, trying to get out there early. They've been able to deliver support to specific communities, and it's just about being able to identify the groups at risks, locations of concerns, or specific methods that are being used. So that monthly group is presented to a smaller group of stakeholders, while the annual one, and there's another one due out in November this year, is presented more widely, but it's not as detailed. Again, in England, it's more or less the same. They get data from 39 police forces every month. That data apparently also goes to local suicide prevention groups. So what they do at the Department of Health is analyze it and send it back out regionally to 400 professionals, and they can assess if the trends in their local area is the same as the national trends. And again, locally, they're able to respond quicker to if there is certain methods, certain locations, certain demographics. So they were able to target sort of prevention methods better. Both are only 2 years old. I don't think they'd say it's perfect just yet. It takes a lot of learnings from all the different bodies involved and different authorities involved, but it's definitely kind of a step in the right direction. They said it was like an early warning signal. That's how they would define it. They still have very long delays when it comes to a natural inquest. It could be 2 to 3 years everywhere. I think COVID had a big impact on everyone's inquest levels as well. But so the official stats are still later coming in, but they can respond a lot quicker for so many areas. And again, I think we are talking about stats and data, but we all know here in the room, there's a family, there's a community behind every single person, and we're always thinking about them and all the work we do.
That's great. Thanks so much, Sarah. It's so nice as well, and I think hopeful to know that there are other countries doing this. So when we're having these conversations, and at least we know we don't have to reinvent the wheel, that there's evaluation and there's things that are already happening that we can adopt and move forward with. What I might do is pass back to Steve and see, do we have any questions in the chat?
Yeah, sure.
That's
Thanks
great.
very
Thanks,
much.
Steve.
Thank you to all the speakers and Louise. I have a comment here. Really interesting, useful presentation. Just wondering on some of the data on women and suicide, and how might we better understand how to classify the numbers better when passive methods are perhaps being misclassified.
I jump in with that, and then if any of the other speakers want to kind of add their own expertise. I think it really does come down to burden of proof in that sense, because having a lower burden of proof allows to take in more evidence and to consider less kind of direct or obvious indications of suicide. So a direct indicator that a suicide occurred would be like a suicide note, and a less direct indicator would be considering things like a history of mental health difficulties or substance use, considering a person's situation or their behavior leading up to their death. and that, you've made a really good point about kind of passive methods that women are more likely to use. So that would be things like poisoning and blood loss, whereas men might die in kind of more violent ways when it comes to suicide modes. And also important to note, as you're probably aware, is that women do tend to have quite a high still suicidal ideation and suicidal thoughts. That they're just less likely to die by suicide. And that's something that requires ongoing research and intervention as well, in terms of addressing suicide by women and suicidal thoughts by women and things like that. So yeah, I do think lowering the standard of proof would be the way to do that. And I suppose as well, having the real-time information might give insights into identifying those less active methods of suicide deaths. So there are interventions such as kind of having blister packs for paracetamol and reducing ligature points in hospitals and things like that have been shown to reduce suicide deaths by stopping people having the means to die by suicide, especially impulsively. And having that real-time information would be able to identify what modes of suicide people are using sooner, and to then prevent them as they are occurring. I don't know if anyone wants to correct me or share anything.
Thanks, Roisin.
No, I
Any thoughts
just
on
if
that?
I could add one little bit is that it is challenging, and there is possibility though of including deaths that, possible accidental overdose deaths as and examining trends and patterns in those alongside deaths by suicide that involve poison or drug overdose. So we can adjust and to better understand are there similarities, and maybe our classification system isn't perfect, but that we can still learn in terms of the patterns by adjusting our criteria for including deaths as a research to answer the research question. But I think again the system will help in terms of if it has a more pragmatic approach, like the probable suicide kind of approach rather than the proof of it.
Thank you, Paul. Thank you. I'm just looking at the clock, and we're kind of coming to the end of our webinar. I'm just wondering if there are any closing remarks or hopes from Sarah, Paul, or Fiona.
Well, I'd just like to thank MHO for putting on this seminar. I think it's a subject that really needs to be discussed and understood at a wider level. I think we can sometimes get lost. People glaze over when we talk statistics and burdens of proof and using a lot of this terminology, but the connection between what it is and how it affects people's lives cannot be overstated. So I hope that we'll return back to this conversation and maybe unpack some of the many sort of aspects which have been, sort of raised and could be discussed further from Roisin's presentation, because I do think a collective response will help move the dial, and the willingness to have real-time data collected, and indeed to encourage the Minister for Justice to revisit the burden of proof.
Yeah, and I just agree. It's just so important that we get the supports in there for people quicker, sooner, prevention measures in, and just having the real-time data and access to that, and all working together, all different aspects of the suicide prevention sort of framework working together to try and reduce those numbers.
Can I just add as well that I think we shouldn't lose hope in terms of the system that's in place as well, because I know colleagues in the Central Statistics Office have worked hard, and their reporting of it has improved as well. And next month they will be giving an update, and it's also they've learned to think in terms of the difficulty of reporting these deaths and the need for support information to be provided, and adapting language to be softer instead of and not stigmatizing. So I think we've come a long way, and we have a long way to go, but I think there's cause for optimism as well.
Thank you. Thanks very much, Paul, Sarah, Fiona, and to Louise and Roisin for such an engaging webinar today. I'd really want to thank you for your expert opinion and reflections on it. So this is one of many coalition conversations that we organise. Mental Health Reform will continue to publish data and hold events like this in different topics affecting mental health in Ireland. So we invite you to stay for the conversation via our website. You can follow us on our social media. A newsletter will be going out in a couple of days as well to keep abreast of the great advocacy work that we do in this sphere. I'd like to take the opportunity to thank the speakers again, but also you, the participants, for being here, for the work that you do as well in your own areas, strengthening mental health in Ireland. So it's only together that we can really do this. Again, thank you for your patience. This is an emotional topic, and I'd just like to remind you of the supports that are there for you. So mind yourself today. Thank you very much, and we'll see you for the next conversation soon. Okay, thank you very much.